Tēnā koutou katoa. Kia ora, afternoon everybody. I'm here to talk about workforce development and its connection to suicide reduction in mental health services. Workforce development, a very broad term, means lots of things to lots of people. It can mean research, we've heard quite a bit about that. It can mean recruitment and retention, it can mean leadership, and it can mean training. And to many people, I think probably it's the latter idea that's synonymous with workforce development. But I hope in this little presentation you'll come away appreciating that workforce development is much broader than simply training. I'm sorry that Joe's gone because I actually attended Liverpool University kind of 30 years ago when Liverpool was a very depressed city, and I was there just 2 months ago, and it's like a phoenix rising. I mean, it's a completely different city. The docks, if you know, anybody knows Liverpool, the Albert docks are now sort of thriving. The story of the Beatles on the dockside there, and the city centre is rejuvenated. And it's just a wonderful example of how things change over time. Anyway, anybody doesn't, for those who don't know much about Tait, we're here. We're funded by the Ministry of Health and Workforce New Zealand, Health Workforce New Zealand. We have a focus on addiction workforce development through mataraki, disability services and adult mental health services. And I want to emphasise the word adult. Traditionally that would mean DHB provider arm services, but I think increasingly, and we've heard this a lot today, we need to include NGO and primary health as part of services more generally, I think. And you can see some of the other workforce centres that we've heard from today, except for the Whakaaro Centre. In this presentation, very briefly, I haven't got much time, I'm going to talk about some of the data around suicide, and we've seen quite a lot of data today already, so I'm not going to spend long on that. And then I'm going to focus on some of the workforce development programmes and initiatives which I think, and the evidence suggests, are most likely to deliver reductions in suicide, which is presumably what we're all here to learn what to do in terms of. In terms of the data, and you'll see it's very historical data, and can I just say a few words about that? I've heard people presenting today very updated data, but that is provisional data. Even the chief coroner was presenting very provisional data. It takes, as the chief coroner was saying, at least 3 years to validate data. We feel very uneasy with talking to provisional data because it does change quite a bit, and so we only use the official numbers which come out of the Ministry of Health. So we're waiting for the Director of Mental Health report coming out in the end of November, which will give us the official numbers around suicides for the next year on. But as we've already heard, there is a lot of consistency, stubborn consistency around the suicide numbers over the past decade. And as you can see from 2013, 308, and each of these numbers is a real person, of course, with family and friends and all kinds of people affected, and got to keep remembering that. And if you look at the numbers here, 37% roughly were service users. That's having contact with mental health services up to 1 year before they committed suicide. And 308 were not. Another way of putting that, of course, is 63% of people did not have contact with mental health services. And you're all aware, demand for services has been going up and up and up. And of course you would expect, wouldn't you, that there'd be a commensurate proportional increase in the numbers of people who are committing suicide within mental health services, and that's borne out by some of the provisional data. But again, we're waiting for the official authorisation of that data. I want to talk a little bit about PRIMED. PRIMED stands for, it's an acronym, stands for the Programme for the Integration of Mental Health Data. This is the Ministry of Health data set for mental health and addictions. There's a lot of data in there, and I won't bore you with all the details, but it's a very rich source of data. There's activity data, diagnosis data, social indicator data, that's around where people live and what work they have, if any, and outcomes data. And I just very briefly want to comment on some of the outcomes data, because our mental health services in New Zealand, that's the DHB provider arm services, they routinely collect outcome data at admission, at review, discharge. And we built up a hell of a lot of data in there now. And we use something called HONOS, Health of the Nation Outcome Scale, 12 items in HONOS. The second item, as you can see, is non-accidental self-injury. And this goes from a rating of 0, no problem, so no problem of this kind during the rating period, that's the last 2 weeks, right through to severe to very severe problem. And here we're looking at a rating of 4, and that's serious suicidal attempt or serious deliberate self-injury during the period rated. And if we look at a 1-year supply of data, so it's quite a lot of data in here. This is for all services, mental health services in New Zealand, both community and inpatient, over a 1-year period, so there's a lot of data. And the colours represent the level of severity, so where purple is no problem, and blue is severe to very severe problem, and you saw the definitions a moment ago of what that means. If you look here, you'll see, as you would expect, people admitted into the inpatient unit are more severely unwell in terms of non-accidental self-injury. That's the blue and the black, so you'd expect that. And on discharge, you can see mental health services have done a good job. They've got people better in the sense that they're not so seriously unwell with regards non-accidental self-injury. And you can see a similar profile with the community. People come in, some people severely unwell in this regard, and on discharge, quite a bit better. But the incongruous bit is this. This is a stacked bar graph for assessment only. So these are people who are seen once or twice by mental health services, community mental health services, and then discharged or referred back to the referrer. And the interesting thing about this, as you can see, is that the level of severity is higher than for people who are actually admitted into services. Now, I was thinking about this a lot, and I just can't get my head around that would be. I mean, this is a non-accidental self-injury, and we're not admitting these people, and yet they're more seriously unwell for this area where people can lose their lives than we are for people who are actually admitted. It doesn't make sense on the face of it.
It makes total sense to me, Mark. So there are people who have no diagnosis.
Yeah, okay. That's one possibility, I accept that. I mean, there's a number of possible reasons, and some of the other possible reasons are around the skills of staff in doing a comprehensive assessment, and we've heard a lot about comprehensive assessments today. The skills in risk assessment, the skills in actually planning care for people. But yes, what you said, David, could well be another possible reason.
There's a lot of people seen through emergency departments who self-harmed, and if we've emergency departments, they're stitched up in the scene once or twice, and the crisis or the intoxication that drove the self-harm reduces, and services don't come up. They might refer to
Perhaps, Steve, perhaps in Canterbury, remember this is national data, so
I'm just
I would want to...
There's a big flow from the emergency department of people who've done something for themselves, who don't get ongoing specialist mental health service care.
And is that HONOS the assessment? What about the discharge after 2 days?
This is, you can see for all the collection periods there, for admission, review, discharge.
You don't receive a HONOS selection.
I know.
So just moving on, so I'm aware of the time, forgive me. So I picked 4 areas of competency, of workforce development that I want to focus on here, very briefly. One is Let's Get Real, which is a national competency framework. It has online assessments, learning modules, value-based practice. It was launched by the Ministry of Health. I was actually there at the launch. Bells and whistles, very impressive. 2008 at the ITA Centre in Auckland. We've been broadly implementing it since then. And we're currently going through a refresh of Let's Get Real. Remember, this is workforce competencies for the whole of the mental health workforce, basically. And it has 7 real skills. Working with service users, working with Maori, working with whānau, working with communities, challenging stigma, discrimination. We've heard quite a bit about that today. Understanding law, policy and practice, and professional and personal development. Each of these 7 real skills have 3 levels. There's an essential level, everybody has to have, basically. No matter what you're doing, cleaning the toilets, you have to have that essential skill if you're working in mental health services. There's a practitioner level for clinicians, and there's a leader level for people who are leading services. And clearly leadership is a vital part of workforce development, as we've heard from Joe first up this morning. And I should say that underpinning the 7 real skills, and really very importantly, we have these values and attitudes. Values of respect and human rights and recovery, communities of relationships, and attitudes. So these are seen as absolutely pivotal and holding the whole thing up. You know, without them, really, there's no foundations, basically. I should also say that in the refresh that we're currently going through, we are looking to extend this beyond DHBs and NGOs, which is where Let's Get Real has been sitting up to now, and moving into primary care as well, hence that movement beyond the kind of siloing of mental health services. We had some stakeholder views when we did our looking to do our refresh. So basically there's broad stakeholder support for Let's Get Real, which is good to know. It provides a common language and agreed approach to mental health care. It's adaptable, flexible, and it's particularly useful for non-registered workforce. And we know there's a growing number of support workers from our more than numbers stock-take that we did a couple of years ago of all services in New Zealand. We know the support work numbers are growing exponentially. Particularly positive things were said about the values and attitudes underpinning the framework. And I guess what I would leave here in terms of this particular workforce development initiative is whether we need to build in something explicitly around suicide. At the moment, these are common, generic skill sets around assessment, risk assessment, planning, etc. Do we need to build in some explicit areas that recognise suicide skills, suicide reduction skills? It's going through a refresh. Now's the perfect time to kind of get in there and change it if we think it's a good idea. The second thing I want to talk about in terms of workforce development is skills matter. This is basically training, postgraduate training for mental health clinicians. It excludes psychiatrists who have their own funding. Quite a bit more, I have to say. But this is aimed at all the other professional groups other than psychiatry. And there's two broad aims, as you can see. Supporting new entrants to develop the required clinical skills and knowledge as they transition into practice, and supporting existing practitioners in mental health and addiction to develop advanced skills in high priority areas, and I would suggest suicide reduction is a high priority area. So we've got these 6 programs at the moment, all provided by various universities up and down the country. New entry to specialist practice for mental health nursing. New entry to specialist practice for allied mental health and addiction. This is social workers, occupational therapists mostly, and some psychologists. Clinical leadership in nursing practice. Coexisting substance use and mental health, big area as you can appreciate, and one that's looking to grow, I think it's fair to say. Infant, child and youth, and the cognitive behaviour therapy. Lots of good evidence sitting behind that particular talking therapy. In terms of the numbers, you can see predominantly, this is from 2016 data, you can see the new entry specialist practice for mental health nursing was by far the largest group, followed by the clinical leadership in nursing practice and various other things. I should say we've had a pleasing uptake by the NGO sector. They've doubled their numbers in these programs in the last 4 years, and that's great, and we'd like to see more NGOs taking part in these programs, not just DHB provider armed services. And you can see by professional group, not many psychologists, but we've had AOD practitioners, occupational therapists, registered social workers, and a lot of registered nurses. And again, there's some question about how we expand the numbers of other practitioners beyond nursing. In terms of feedback, and for those of you who can't read what it says down here, basically it's asking questions such as, statements such as, my course included adequate opportunities for practical experience. You can see most people agreed, that's the orange bar. I've been able to use my training in practice. Again, most people agreed with that. My clinical settings, placements enable me to develop my clinical skills. Most people agree with that. I've shared my new learnings with colleagues. Most people kind of agree with that, strongly or fairly strongly. And I'll use my new learning practice in the future. Most people very strongly agree with that, and that's really what we want to see. That people are going to actually apply some of their learnings into practice. I guess, again, one of the questions I would put, going back to the programs that are being offered, is do we need an explicit program around suicidality and working with suicidal people? That's a question. Again, it's up for discussion. Moving on very quickly, I haven't got time to go into any detail here. I'm sure you can appreciate. Talking therapies, we've been working with the ministry and other groups over the last 10 years to produce a lot of guides and resources, online material around talking therapies. I think we'll all agree, we've heard today a lot about this. Talking therapies, I prefer that term rather than psychotherapy, by the way. Talking therapies provides a real avenue to kind of intervene early and perhaps identify people with mental health problems. Look, I'm very much aware that there's a lot of work in this space. This is just one example. I fully acknowledge that. Te Huka resources for wellbeing, we like this term, resources for wellbeing, rather than focusing on suicide. Is a real opportunity for primary health providers, particularly GPs, to provide assessments of people and then prescribe some evidence-based online e-learning material or some written resources depending on their assessment, and then obviously follow it up and see how people are doing. And this connects to e-therapy, which is, again, this burgeoning area that I think we all need to get our heads around in terms of workforce development, because not many of us have skills in this area. That's not what we trained originally in. And yet this is clearly where we're heading, and we need workforce development in this e-therapy area fairly quickly, I'll put it to you. Just moving on, way the time short. Workforce planning, in some ways, this is my fourth area of workforce development. Often doesn't get much of a mention, and yet it's arguably as important as anything. Because if we're not planning, if we don't know where we're going, any road will do. How does it work? Well, it really takes some of the policy that we've heard about today, some of the strategy, some of the trends, some of the plans and the data, and it feeds them into a little matrix where you're looking at the what services are needed in the future. Do we need more psychologists? Do we need more therapists to offer talking therapies? Do we need fewer nurses? Do we need fewer doctors? I don't know, these are questions. What does the workforce need to look like? And what does the current workforce look like? And what are the gaps? And I put it to you that working with people who are potentially suicidal is one of the big gaps at the moment. We clearly are not fully addressing this. There is some gaps here, and this is a potential for the workforce to be upskilled. And that leads to workforce development. And if you like to finish on shameless self-promotion, forgive me, if I can, so there's some resources around workforce planning if anybody's interested in reading more about the process of how you plan, what services you need at various levels, and getting it right so we've got the workforce we need to deliver the sort of outcomes we want. And the Shameless Self-Promotion is a book that myself and a colleague, Angela Jury, put out last year, IGI Global. It's an international resource, been actually well received around the world, let's say. And it covers in much greater depth, as I'm sure you can appreciate, workforce development, some of the theories and models underpinning workforce development and some of the practical applications. And we use examples from North America, I have to say not crisis response model. I've had some problems with that one. It covers North America, parts of Europe, parts of Asia, and obviously Australia and New Zealand. Thank you very much.